Welcome, and thank you for joining us for this CME activity, Clinical Conversation, addressing the issues and diagnosis and management of fibromyalgia. I am Rick Pope, a physician assistant from the Rheumatology Division of Danbury Orthopedics in Danbury, Connecticut. Joining me for today's conversation is Joan McTigue from the Division of Rheumatology at the University of Florida College of Medicine in Gainesville, Florida. In this activity, I will be discussing with Joan many of the challenges that primary care clinicians often encounter when diagnosing or managing patients with fibromyalgia. We hope that through this activity, learners will be more confident and better informed about the diagnosis and management of fibromyalgia.
Well, Rick, as you know, descriptions of fibromyalgia have been around since the early 20th century. In fact, it used to be called fibrositis, and the name was later changed to fibromyalgia because of the symptom of pain, not inflammation.
I remember those days. I'm actually old enough to remember that.
Yes. So our activity today is going to discuss how primary care clinicians can diagnose and manage patients with fibromyalgia. In the 1990s, the ACR developed criteria for the diagnosis of fibromyalgia, but a lot of people feel it falls short, and most experts now feel that there are some essential, some core features that are coming into their own. Are you familiar with the 1990 criteria?
I'm kind of an old dog, and I do use the 11 out of 18, but not for a strict definition, but more for a kind of a generalized. At least I feel more comfortable with that in terms of making the diagnosis. And I think we should discuss those because I think they're coming to the foreground pretty soon.
That's true. I mean, there's been a push, and the push is in the direction of thinking about fibromyalgia as more a symptom set. A person would have a history of widespread, moderate to severe pain that persists for 3 or more months in the upper and the lower body, bilaterally. And those are supposed to be so bad that they interfere with the activities of daily living. And I certainly find that they do in patients I see with it.
Yes, me too. I think the biggest discussion that we're probably going to have over the next few minutes is how to make sure that that's actually what the diagnosis is. Widespread pain is common with other forms of inflammatory arthritis, as you know.
Yes.
And certainly generalized osteoarthritis can give you widespread pain as well. So those are important fine points that we need to kind of decipher.
And these folks usually have fatigue, a lot of fatigue with usual activities. They'll often describe a poor sleep pattern. And they often have changes in their mood and their cognition. And a lot of the symptoms are not easily explained by the usual history and physical that we do. In fact, a lot of times the physical exam's unrevealing. Sometimes you'll see hyperalgesia. These tender points may or may not be there. New proposed ACR criteria doesn't require tender points as part of the diagnostic criteria for the diagnosis of fibromyalgia. And I've found over the years that many persons, particularly men, don't have tender points, yet they still, I'm certain, have fibromyalgia. So I'm interested in these new criteria, and I'm kind of glad to have a little bit of the shift off of the tender point exam, although I do find that when they're there, it's quite useful. Tell me what you think.
Well, I'm from the old school in the sense that I like to actually do a very careful tender point examination, and when I find the tender points being positive, it makes me feel a little better about what the diagnosis is. So I still use them, and from my point of view, I think the audience should still use them and learn how to do a very good anatomical specific location tender point exam. And until that point, I'm going to continue to use them. However, I would say that I think that I'm anxious to see the new guidelines too, because I think we're going to be able to use tender points to some extent, but it won't be as much of the criteria, more the chronic widespread pain along with the other associated halo-like symptoms.
Exactly. That's how I think about it too, and I'm welcoming them. The 11 out of 18 tender points, can be a little tricky to do. I mean, you've got to apply about enough pressure to make the fingernail of the examiner blanch.
Yes. Yeah, that's a good point. And I think one of the things that I teach PA students who come through my practice is actually where to put those trigger points in position to actually to elicit them. And I find it very interesting that if you're off by a little bit, sometimes you won't find the trigger point. And I've seen, people, I think you suggested this earlier when we were talking, is that people just say, oh, is it tender here? Yes. Is it tender here? And that's not really a good trigger point examination.
It's not. I mean, they really are anatomical locations that have been validated. So I think if clinicians are going to use trigger point exams, they need to use them accurately and apply enough pressure.
Good point.
To really elicit tenderness. Now, there's a lot of associated multi-symptom syndromes that kind of ride along and have a kind of halo effect around this pain problem. I know a lot of patients will complain of pain, dizziness, multiple allergies, numbness in the hands and feet, and also sometimes some GI or GU problems as well. And what I've found when I think about it is some of the features are more neurobiologic and others are more psychosocial. And I think of the psychosocial ones as fatigue, often poor sleep, cognitive changes. Patients talk about fibrofog. Do you hear them talk about that?
Yes, they come in with that term, and I'm always wondering what that is. And I think how they define it is I can't remember clearly. I'm never quite able to concentrate enough. I feel like I'm in kind of a fog.
Yep, they have a difficulty with attention, concentration, and they feel overwhelmed a lot. That's something I've noticed a lot, and it's, really our depression and anxiety features to this. It's important to kind of sort out a few things in terms of what to do before a workup, particularly in terms of labs and x-rays. I think there's some bottom line labs that are useful. I try to discourage routine testing, routine costly fishing expeditions, but I think a basic workup should include a CBC, a basic metabolic profile, certainly thyroid function testing. A vitamin D level is not a bad idea. Mm-hmm. And looking for some inflammatory markers, like a CRP or ESR, I think are useful.
One of the things that I think about when I actually make the diagnosis is how actually we come to that diagnosis. And I think the laboratory examination is very helpful. But on the other hand, and I don't know if this is your experience, but sometimes we have very subtle cases of inflammatory arthritis. Particularly, I think about in the spondylitis category. For example, if I can give you an example, we had a police person who was 31, a male actually, come in, and he had about 2 months of chest pain, anterior wall chest pain, that suddenly went to his neck and shoulders. He had some degree of poor sleep, and it was very difficult to determine whether or not he had fibromyalgia or maybe the first onset of an inflammatory spondylitis. And I think primary care practitioners really need sometimes to have somebody that they feel comfortable with to refer to kind of sometimes sort out some of those things. And in reference to the laboratory work, I agree. I think all of these things are important. They can be confusing, but hopefully they'll be fairly straightforward. Hopefully all the laboratory work will be normal, and the sedimentation rate and CRP will also be normal, and that will help you. So I think all of those things are very important to do, and each case is a little bit different. Do you find that?
Well, I find that sometimes the inflammatory markers can be just ever so slightly elevated, and I don't think, generally speaking, that that's significant, particularly in obese people who actually have a little higher circulating levels of inflammatory cytokines such as IL-6. And I think regarding imaging, I think in general it's not useful. I let it be driven by the symptoms. If somebody has chest pain that seems to be localized to certain joints, or low back pain that tends to be sacroiliac, then it can be. But I think in general imaging is not very useful and can be costly. There's a case I'd like to kind of tell you that came to me, and it's a kind of typical case, and I'd like to know if this is a typical case for you. Recently, we saw a 40-year-old white woman, married with 2 children, and she presented with the chief complaint of, I feel awful, tired all the time, poor sleep, no energy, just sort of general fatigue, and also complaining of pain in her neck, her shoulders, her lower back. She'd had a tubal ligation a couple of years ago, and her menses were no longer heavy. And she'd been getting, tests regularly. She'd seen quite a few people. normal TSH, normal vitamin D, normal BMP, CBC, all normal. She's not a smoker, not a drinker. She is overweight by about 30 pounds over her pre-pregnancy weight, and that bothers her. She doesn't exercise, however. She's tried a number of simple things, Tylenol, over-the-counter NSAIDs. Didn't do much for her. And she's kind of done some experimenting in herbal and vitamin therapies. Not so much. Nothing's done a whole lot for her. But she's very frustrated, and so is her husband.
Yeah, I think that's a very common presentation. I see that a lot. And what's really interesting to me is when I look at a patient like this, oftentimes they've seen 4 or 5 different physicians before they got to us. Yeah. And they're looking for someone to try and put the whole picture together. Yeah. And I think that's really where we need to kind of focus our concern, is to kind of say, okay, this person has some of this widespread pain, maybe some irritable bowel, maybe some interstitial cystitis, headache history, and all of those things, depression, anxiety, can be put together in kind of a tent that includes all of those things under one kind of heading. And I think for us as practitioners, it's really important to separate out what they have from what they don't have. And I think that's really where part of our consult practice in rheumatology really comes in, is to put the stamp, so to speak, of fibromyalgia, if you want to call it that, on the patient so that they can have something they can actually kind of put their hands around.
People like to know the name of what you think is going on, really.
And we like to know the name, too. I mean, you and I, when we sit there in front of the patient, I think it's very clear. We want to know, what do we really think you have? And one of the things I find very interesting, if I may interject here, is when I teach inflammatory arthritis versus mechanical arthritis, i.e. osteoarthritis or mechanical low back pain, stiffness is a big separator there. One of the things that fibromyalgia, I think, is very difficult to understand is to understand that fibromyalgia has a significant component of stiffness that would lead you down the inflammatory pathways. But what they don't have is active synovitis, and I think the examiner needs to make that point very clear, that there's no synovitis in the hands, no synovitis in the wrists, et cetera. And I think if that's not there, then you can kind of start working your way down the diagnostic path of sorting this whole process out.
Well, I think the history and the physical are key. Chasing vague symptoms with testing and imaging, I think, is futile. I think the answer really lay in the history and the physical. Seeing the big picture is the most accurate way to put it together. Kind of the 10,000-foot view, right. I think, is a whole lot better. And I think that the hallmark is clear. It's widespread pain above and below the waist, lasts for over 3 months, affects both sides of the body. It's moderate to severe, interferes with their daily life. It's exhausting for the patient. And it's often accompanied by other multi-symptom, kind of neurobiologic, or in some cases, psychosocial symptoms. And I think that you're right. Most of the time when we see them, frontline self-care therapies have failed. We'll go on to discussing some of the other aspects of it.